All right, thank you everyone for coming out tonight to a very special Forefront Talk series. I couldn't be more excited about our topic that we have today because, as you all know, Next Health is a health optimization center. Our goal is to bring together the best treatments, technologies available in the world in relation to health and wellness so that you guys, everyone here, can have access to the best and can take charge of their health and can optimize their health. And there really isn't a more important topic than stem cells when you're talking about longevity and health optimization. And I'm thrilled that we are now offering this here at Next Health so that you guys can start taking part of this longevity revolution. We have a very important speaker tonight who is on the forefront of everything related to stem cells. And stem cells have been discovered, I think, about 40 years ago. There's a lot of information. There's lots that's transpired since that point. And there's also a lot of confusion around it. So Dr. Gavin's going to help clear all that up. He's going to give you guys some updates as to where we are today, what we're able to do, and what's on the horizon for stem cells here in the U.S. So please welcome Dr. Alan Gaveck.
Thank you. I took the long walk, and he gave that introduction exactly how I wrote it, right? So we do want to talk about stem cells tonight in reality. There's a ton of nonsense on the internet because you've all seen it. That's why you're here, you see it. Let's talk about reality. Let's not talk about fantasy. We got to know what stem cells are really about, because if you listen to a lot of it, it's a lot of nonsense. So basically, historically, I want to give you a perspective about stem cells. People tend to think that like stem cells are this brand new phenomena that landed on Mother Earth, right? You read about it 3-4 years ago. Oh my gosh, stem cells are brand new, right? They were discovered in the 1950s by a doctor named Dr. Friedenstein and his colleagues. And they discovered cells that were different than any other cell. They knew cells would duplicate themselves, but they found cells that actually changed into other types of cells. This was in the 50s. By 1968, they had performed the first successful bone marrow transplant. At the time, they thought it was just bone marrow. What we now know is the stem cells in the bone marrow that took place. In 78, they discovered stem cells in cord blood. In the 1980s, UCLA, in conjunction with Penn State University, discovered stem cells in fat. And I mean, like me, that means a lot of stem cells on board, right? After that, within a few years, they discovered stem cells every tissue in the body. Your eyes, your skin, every organ in the body. And they found out every single tissue in our body has its own stem cells on board. After that, the race was on. Things were really starting to happen, and they happened very rapidly, and that was in the 1980s. So just for clarification, usually I have a screen up and you're all looking at it and seeing it. We need to kind of, get some definitions. I usually speak to physician groups, but it's nice to, talk to patient groups also. There are basically 3 different types of cell therapies you could have. You can have an autologous therapy, which is from your own body, whether it's bone marrow or adipose tissue. You can have an allogeneic, which is from something in the same species, which is what we'll talk about, umbilical cord blood from a live, healthy birth baby. Or you could have a xenograft, which is what we see in other parts of the world where they take it from like an animal, a sheep, a cow, a duck. Believe that, right? So these are the 3 different types, but tonight we'll primarily talk about umbilical cord blood, which is an allograft. So the International Society of Cellular Therapy made a definition of about 20 years ago of what is required in order to be determined a stem cell. Now, this is more stuff what I usually talk to physicians about, but the bottom line is this isn't rocket science. This is not some mathematical formula that you have to have a science degree in order to figure out. This is basic stuff, right? So the International Society for Cellular Therapy said there are 3 main criteria that you have to have for a stem cell. Number 1, it must be plastic adherent. And when I'm in physician groups, they're thinking of themselves, oh my God, so I put it into a syringe and I try to put it out of a syringe, it's going to stick to the plastic walls. No, what plastic adherent means in these mechanisms in the scientific world is you put a plastic pipette into a colony and negatively charge it, only the stem cells are attached to the plastic. So that's number one, plastic adherence. Number two, it must contain three main properties: CD105, CD73, and CD90. We could have a 3-hour conversation about CDs, which are called cellular differentiators, but essentially every single cell in our body has approximately 339 cellular differentiators. As an example, CD56 is a natural killer cell. When you get some bad cell in your body, CD56 breaks off to your cells and chews on it. CD34 is made for cartilage, and it goes on and on and on. For stem cells, you need to have CD105. CD105 is for hematopoietic stem cells. That just means cells that will recreate the blood system in your body. If you have leukemia and you need a bone marrow transplant, they'll irradiate your cells and give you bone marrow from somebody else, and what they're looking for in that product is CD105, because it will completely reconstitute the blood system in your body. The second component is CD73. CD73 in our human body is specific against tumors. It causes tumor suppression. That's why you rarely hear of cancer in children unless it's genetically disposed, right? Because CD73, our natural component, keeps it down and knocks it down. The third component, which we are most in deal with, is called CD90. CD90 has to do with cells in our body. CD90 gives cellular extravasation, cellular migration, cellular adhesion, all the things that we are looking for in the cells. So I know this is getting terribly boring, and I'm probably the only one in the place that's interested in it, but it's cool. The third differentiator that defines a cell is it must be able to differentiate into osteoblasts, which are bone, adipocytes, which are fat, and chondrocytes, which are cartilage. And that's the good stuff for us right now. So that actual definition was written almost 20 years ago. And in the definition, they said, we do recognize that this will probably have to change over time. For the purposes of what we're going to talk about tonight, stem cells, what we look for in the lab and what we look for to treat patients need to have two simple qualities. Number one, they have to be renewable. Stem cells are renewable. What does that mean? That they have the capability to undergo mitosis and duplicate themselves. That's what they do in our body, and they have the ability to do that. Number two, stem cells have potency. Potency in the stem cell world doesn't mean strength. You know, I'm super potent. Potency in the stem cell world means the ability to differentiate into other types of tissue. So, for umbilical cord stem cells, which we'll talk about tonight, umbilical cord blood stem cells have the potential to duplicate themselves every 24 hours for up to 90 generations. And that's in a perfect environment, which is typically in vitro or in the lab. Imagine if Bank of America did that, right? 100, 200, 400, 800, right? It would be awesome. So that's what stem cells have the capability to do. Now, bone marrow and aspirant in our own body also have the capabilities to do that, but it's completely limited by our age and the health that we have in our body. Scientific studies show that by age 50, and I wish I were only 50, our amount of stem cells in our body are significantly reduced. And if you happen to have an autoimmune disorder also, then the stem cells are even less. They have even less capabilities. So, to be very clear, mesenchymal stem cells, which we're talking about tonight, and I'm going to bore you with a whole lot of science. Mesenchymal stem cells that we're getting from an allogeneic source, right? Not our body, but somebody of the same species, have the ability to duplicate, but they probably do not duplicate in our body. And the example I can give you, if we took these umbilical cord blood stem cells and we put them in the blood of, say, a baby or a youth or an infant, and put them into a culture, into an incubator, every 24 hours they would duplicate themselves, and it would happen for probably up to 90 generations. If we took those same cells and put them into our body, well, my body anyway, you guys are probably a lot healthier than I am, put them into my body, the potential for duplication is significantly reduced because we've lived on this earth for 40, 50, 60 years, and our bodies are somewhat toxic. So it's not a beautiful environment to grow cells. So these allogeneic cells, while they have the potential to duplicate, whether or not they duplicate in our body is unknown. However, they produce long-term effects by responding to signals from injured tissue. And among those primary effects is modulating the inflammatory and immune response that happens in our body. As we get older, these responses tend to get stronger, right? You walk through a doorway and bump your elbow. When you're 10, 11 minutes later, that situation's over. When you're 50, a couple weeks later, you still say, damn, my elbow is still sore, right? So stem cells have the ability to modulate these things. And how do they modulate it? Because these mesenchymal stem cells secrete these very specific factors. Things like, get ready with this, I hope somebody's writing this down, TSG6, PGE2, TIMP2, and interleukin-1 RA. So it'll be a small test afterwards, but don't worry about that. So mesenchymal stem cells have the potential to secrete these things to help our body. They also synthesize things as growth factors, cytokines, exosomes, all things that you read about, and microRNA. So the whole point of that is, while stem cells have the capability to duplicate themselves in our body from an allogeneic source, probably not so much. So what I want to talk to you about briefly now are the things that are secreted by mesenchymal stem cells. And usually I have it up on a screen and everybody's looking at it and you can say, oh, TSG6. So TSG6 is a short acronym for a long word. It's called tumor necrosis factor alpha stimulated gene protein 6. You notice I had to look at the screen because I always forget what that means. Basically what TSG6 does is it suppresses the inflammatory component of tumor necrosis factor alpha. That's why it's called tumor necrosis factor alpha inhibited gene protein 6. It suppresses the function of tumor necrosis factor alpha. Tumor necrosis factor alpha is the #1 cytokine that happens in your body when you have an inflammatory response. It is the responder. Mesenchymal stem cells push that down. #2 is PGE2. PGE2 stands for prostaglandin type 2. Some people will be familiar with prostaglandins. Prostaglandins are the pro-inflammatory components in your body. When you take a non-steroidal inflammatory drug like Motrin or Aleve or something like that, it suppresses prostaglandin. Well, that is suppressing prostaglandin 1. What mesenchymal stem cells form is prostaglandin 2. And prostaglandin 2 works through our T receptor cells to actually cause an anti-inflammatory response in our body. So this is everything that these stem cells are doing in our body. The first two things, they're eliminating and they're inhibiting inflammation. The third thing that I'm going to talk about, I mean, there are hundreds of things that it secretes. The third thing is called TIMP2, tissue inhibitor of metalloproteinase 2. So it inhibits the formation of the matrix of metalloproteinase. What is metalloproteinase? Metalloproteinase is a substance. You guys are getting caught up in these words, aren't you? They're like, what the hell is metalloproteinase, right? Metalloproteinase is a substance that breaks down type 4 collagen in our body. So anytime you have an injury, you're out running, you twist your knee, you have an injury, your cells automatically create the metalloproteinase 2 and 14. Metalloproteinase 2 and 14 break down type 4 collagen. What is type 4 collagen? the tissue that holds every single component of our body together, whether it's skin, cartilage, bone, lung, liver, it doesn't matter. It's called the basement membrane that holds all of our body together. So when you have an injury, whether it's a physical injury or a chemical injury, MMP2 is breaking down tissue. Stem cells secrete the components that stop that from happening. It's the tissue inhibitor of metalloproteinase 2. The third one I'm going to talk about is interleukin-1 RA. The major cytokine, don't worry about the words, just get the concept. The major cytokine in our body, pro-inflammatory cytokine, is called interleukin-1. Well, stem cells secrete a component called interleukin-1 RA, interleukin-1 receptor antagonist. So it stops the signaling of interleukin-1 to create inflammatory components. So the reason I kind of go through this process when I talk to physician groups is they'll say, how long, actually it's patients who say, when am I going to feel the effect of this amazing thing you're going to put in my body? Well, you know what, it's going to take a minute. Because of those 4 things that I talked about right there, which are just 4 of hundreds, only one of them, interleukin-1 RA, is the only one that works in sight. It stops the chemical signaling. The other 3, TSG6, PGE2, TIMP2, actually stop the downstream formation of new inflammatory components. So you got a bad knee and you have an injection inside your knee joint, it can take days and even a few weeks before you really start to feel effect, because the only one that actually works at site is interleukin-1 RA. The other ones work so that the components are not developed and put into the joint. So what that means is those inflammatory components that are there, the prostaglandins, the metalloproteinase, the tumor necrosis factor alpha, the interferon gamma, they have to go through their life cycle. And those life cycles can take several days up to a couple weeks to go down. So if you have an injection because you have a bad joint or you have a musculoskeletal thing, it can take a while for these things to take effect. Interleukin-1 RA is the only one that happens. There are other major things that happen with stem cells. Anti-apoptosis is a very big effect. Apoptosis literally means cell suicide. When cells in our body get old, they normally will burst their cell wall, spit out their DNA, and die. The lymphatic system will pick it up and take it out of our body. When there's a space created by that, the body will lay down new tissue. However, what about if I've had a stroke and I had a blood clot in the area of my brain, typically the circle of Willis, and I have damaged tissue that is happening because of that stroke? If you have enough stem cells at the site, the stem cells can stop those cells from having to die. They can nourish them back to health, and they can give these healthy cells the stimulus in order to create new cells, and you don't have to undergo the process of the results of having a stroke. So anti-apoptosis, it helps give nutritional support to damaged cells, is very important. Another big capacity of stem cells is antimicrobial, antibacterial. There are multiple studies going on around the world right now, and it's actually not a new concept because it's been around for the last several years, but there's a specific polypeptide called LL37 that they think is really the big thing involved here. They're treating patients with systemic disease, bacteremia, or acute or chronic bacterial infections just with stem cells, and it's very effective. The reason this is so big around the world, not so much in the United States because we have limited use in the United States, but around the world, they're also very effective against protozoa. So when you look in the eastern United States or the northwest United States where there's Lyme disease and you have protozoa with babesia and that sort of thing, that's a huge component. And these stem cells are directly against that. So he wants K1 through 6 on how the cells work. We'll get to that in a minute. So far, and I will, and I do get to that. So far, what we see with mesenchymal stem cells is they're anti-inflammatory and they modulate the immune system. What does that mean when they modulate the immune system? If you have an autoimmune disorder, rheumatoid arthritis, Crohn's disease, multiple sclerosis, all those different things, your T1 helper cells, which are your pro-inflammatory cells in your body, are completely out of whack. And your T2 helper cells, which are your anti-inflammatory cells, aren't reacting. These balance them out. So that's what mesenchymal stem cells do. They have anti-inflammatory and immunomodulatory, and we talked about, 3 or 4 of those. So what next? What happens next? So now that we have the MSCs, say, in this injured environment, a joint, a shoulder, soft tissue, whatever it is in your body, these MSCs will secrete these multiple anti-inflammatory factors that will inhibit this inflammatory process. It doesn't matter if you're talking about in your joint or you're talking about your systemically. It'll inhibit this inflammatory process. These MSCs now have the opportunity to optimize the environment around these damaged cells. Decrease the inflammatory component around the damaged cells, and now they're optimized. Once you have that area optimized, your own body now has the capability, as if you're 10, 15, 18, 20 years old, to begin to do tissue repair like it used to do. Well, when I was younger, I won't say for you guys. The growth factors, cytokines, exosomes, and microRNA now work along with the umbilical cord stem cells, along with your own body to begin to regenerate damaged tissue. So the next part, I just want to talk to you about a few growth factors, then I'll get into the simplicity of it. But I feel like if I don't at least give you the potential of the scientific basis of why the cells do what they do, then we're just talking about magical crap, and that's not what it's about. It's really not. It's about science. It's about what the science does, and it's not science fiction, right? This is not Star Trek, and we don't go Mach 6 or whatever the heck it is, right? It's science, and if I don't give you that basis, I don't think we can get there. So the other component I talked about, besides the MSCs, the mesenchymal stem cells. By the way, mesenchyme just means tissue. Chyme is tissue. There are growth factors that they also secrete. Multiple growth factors, such as VEGF, vascular endothelial growth factor. Another big word. What does that mean? Vascular endothelial growth factor. It stimulates your body to create new blood cells. If you have damaged tissue, cells have been damaged and there's lack of blood supply. So with vascular endothelial growth factor, it stimulates your cells to have new blood supply in that area, and you can grow new cells. There's a thing called FGF2, fibroblast growth factor 2. Fibroblast growth factor 2 stimulates healthy cells to begin to multiply, undergo mitosis, and duplicate themselves. If you're a long-term runner or you had an injury and the cartilage is wearing off your knees, right? When you're young, no big deal. Cartilage grows back because that's what we are. FGF2 stimulates those healthy cells to do what they're supposed to do. Stimulate, and those cells begin to duplicate themselves. So instead of having this area with no cartilage on it anymore, the areas with healthy cartilage start to cover that up. And that happens through the stimulation of fibroblast growth factor 2. There's a lot of immune cells, regulatory T cells. I won't get into that, but that's balancing of the immune system. In autoimmune disease, we say that specifically. There's also a component called SCF, and we'll talk about this again in about 2 hours. But SCF is called stem cell factor. Stem cell factor, when you put these cells in your body, it stimulates your own endogenous stem cells, the stem cells that you were born with, to become activated and do what they're supposed to do. The example I give you is, I used to have hair in these areas in my head. It's not there anymore. But if you pulled those follicles out, that stem cell is still alive. It's just inactivated. If you activate that stem cell, and it makes no difference if we're talking about a knee or a liver, the same thing is happening. Stem cell factor, which is secreted by these mesenchymal stem cells, stimulates our own endogenous stem cells to become activated. When our own stem cells become activated, we can begin to create the tissue that we need through our stimulation. There's also a thing called endothelial progenitor cells. We won't get into that a lot. It's very big in erectile dysfunction because when you stimulate the endothelium of a blood vessel, you have massive release of nitric oxide. The cells open up and it happens. Fibroblasts, they secrete fibroblasts, which are a structural framework for tissue. They secrete nerve growth factor, NGF. I don't like people to get really caught up on nerve growth factor because then they tend to think that, you know, my friend that's been in a wheelchair for 40 years, we can inject it in their spine and it's going to regrow a new spine. That's not what happens. That's kind of a scientific process where you need oligodendrocytes in order for that to happen, and it's not in here. But nerve growth factor will stimulate nerves that are damaged in order to nourish themselves and become healthier. And towards the end of the growth factors, platelet-derived growth factors are important because they stimulate cell growth, but they stop it. They regulate it. You know, people wonder, I got a damaged ligament or tendon. I mean, is it going to put too much down there? Platelet-derived growth factor will stimulate the growth, but when it has enough and it's at that God-given area, it stops it. And then there's a thing called transforming growth factor beta, which stimulates the growth of cartilage, knees, hips, elbows, all that sort of thing. It stimulates the cartilage to grow, but it stops it when there's enough. So let's break it down, as Kevin said, into what exactly happens. Damaged cells in our body put off a chemical signal. It's like that white flag. And that chemical signal are these inflammatory components. Tumor necrosis factor alpha, interferon gamma, all of the cytokines 1, 2, 8, and 12, and they're all stimulated because damaged tissue puts off an inflammatory component. When you have umbilical cord blood stem cells put in your body, they are attracted to that inflammatory component. They will attach to a nearby microvesicle and become what's called a pericyte, not a parasite, pericyte, and they will begin to give medically called trophic support to that area, nutritional support. They will speak to each other. This one, the healthy one, says, Jackie, what's going on? Oh, I had a crappy day, and I haven't had any ham sandwiches, and they speak back and forth, and it takes a damaged cell and potentially makes it a healthy cell. This is called paracrine signaling. Most people in here are familiar with the endocrine system. Diabetics go to an endocrinologist, right? Or if you have hormonal issues, you go to an endocrinologist. Why? Because the endocrine system is our entire body. It's the hormones and the chemicals that flow through our entire body. That's endocrine. The paracrine system is the signaling between every single cell in our body. We have trillions of cells in our body, but they're talking to each other all the time. So when you have a damaged cell, but next to it is a healthy cell, young, healthy, vibrant cell, it can give signaling mechanisms to that damaged cell and make it healthy. And that's the whole point of these umbilical cord blood stem cells. They have paracrine signaling capabilities that are attracted to inflammatory components. They decrease the inflammation. They help damaged cells to become healthy, stimulate healthy cells to undergo mitosis and duplicate themselves because you want more healthy cells, and then stimulate our endogenous stem cells to become activated. Because by age 40 to 50 and 60, 70, 80, our own stem cells are pretty much quiet. They're pretty much inactivated. And that's what the capability of the cells. So not to be completely lame, but we'll review it one more time. When umbilical cord cells are injected into the body, these mesenchymal stem cells secrete anti-inflammatory and immunomodulatory factors that optimize the environment, take away the inflammation. These live nucleated cells, they're alive when they're put into your body, secrete these growth factors that we talked about. They nurture damaged tissue to become healthy and stimulate healthy tissue to undergo mitosis or duplicate itself. These live nucleated cells also stimulate the stem cell factor, SCF, that we talked about before, which stimulates our own stem cells within our body. Not only to become activated at the site, wherever your injury is, but to be activated in our bone marrow so that they will migrate to that site and actually begin to create new tissue. So this, so this is all the stuff we talked about, but we won't do that now. So just for a moment, I talked about live nucleated cells towards the end. Umbilical cord blood stem cells are live. They're alive. We have to treat them and cryopreserve them in a certain way so that they're alive. Is that important? It's incredibly important because live nucleated cells will continue to create growth factors and secretions for weeks and months in the body. Studies have been done on joint injections where 9, 12, and 15 months after the injection, they've done arthroscopic evaluation and MRIs, and the joint is still changing. Now, the cells are not alive at that point in time, but these live nucleated cells have set up a cascade that continue to work. It's the same thing with the tissue in your body. The joint is just what we deal with mainly. So where can you find these live cells? You can find them in umbilical cord blood, which we're talking about. You can also find them in bone marrow. You can stick a shiv in my back and get some bone marrow out of there. And you can find them in adipose tissue, and I got plenty of that too. Problem is, as we age, our cells age. My bone marrow is almost 59 years old. Actually, add 9 months to that, my bone marrow is damn near 60. That's horrible, right? I forgot about that 9 months in between. And the same thing with the adipose tissue. Our own tissue is dependent upon our age and our health. So you're going to hear about their other companies. How about non-nucleated cells? When I'm talking to doctors, they know what this is about. Non-nucleated cells. You're going to amniotic fluid and placental tissue and all this sort of thing. Does it work? Yeah. But according to how that tissue must be processed, there are no live cells in there. And, okay, I'll go down that path. If I were you to do an amniocentesis in a pregnant woman and pull out the amniotic fluid and analyze that tissue, there are live cells in there, and there are live stem cells in there. However, think of the environment that's in for 8 or 9 months. When that environment comes to the outside environment, inside the uterus it's completely sterile, no problem whatsoever. When it comes to the outside environment, the potential for microorganisms, bacteria, is very high because of the environment that it's in on the inside. So the FDA requires that they must do a process called snap freezing. Immediately drop it to minus 80 degrees centigrade so that all live cells burst when they freeze, right? When they get the crystals in them. Therefore, amniotic fluid, placental tissue, all those sort of things have no live cells. Do they have value? Sure. You can put them in a joint and they will last from a few hours up to even a couple of days. But you don't get that long-term effect that you get from live nucleated cells. So the other thing you got to think about in your mind right now is it safe? right? What's the whole safety protocol here? First of all, these are 9-month-old cells, 9-month-old in utero cells. They're naive, and they do not have the same blood markers that we as adults have. When the stem cells are removed from the cord blood, so when we get the cord blood, well, I'll take you from the beginning. We only primarily use pre-planned cesarean sections. So at 36 weeks, right, 1 month before planned C-section, mama goes to the OBGYN, and he says, hey, would you like to keep that cord for your baby? Less than 10% ever keep it, and it's probably a cost issue because it's kind of expensive. So then the doctors we work with say, would you like to donate it? And most people are pretty cool about it. They're like, yeah, I'd like to. So if that's the case, then mama has to undergo medical review, social review, lifestyle review, travel history, medical history, family history, all of this sort of thing to find out if she's a candidate. If she is a candidate, then she has to have a blood test, rule out HIV, herpes, tuberculosis, all of the major communicable diseases. If all of that stuff is passed, then at the time of delivery, a certified technician will go in and take the cord, drain the blood from the cord, and take it to our lab. At our lab, a simple spinning down process removes about 90% of the red blood cells. The red blood cells are the problem. If me and you are going to switch blood, we better be the same type, or we better have a generalized safety margin in there. If you remove all the red blood cell components, now we don't have to worry about compatibility, about what they call ABO compatibility. We go through a secondary process after that because we know about 10% of those antigens are still there, HLA-DR primarily. I don't have to, you guys all know what HLA-DR is. So we go through a process to take the rest of the 10% out so that we have a product that is then considered immunoprivileged. Well, that should be cool then, right? We got this immunoprivileged product. No, it's not enough for the federal government. We then have to take 10% of that product, send it to a certified third party, it can't be in-house, CLIA certified lab. CLIA is just a hospital certification for a lab, and have it tested for what's called USP Rule 71, United States Pharmacopoeia Rule 71, which is communicable disease and sterility. When I'm talking to physicians and I say, this is a 14-day test, they understand. You can grow things like gram-positive bacteria, Staph aureus, and all that sort of thing in 2 or 3 days. They grow it for 14 days because things like gram-negative bacillus that come from the gut and the GI system can take 10 to 14 days to show up. So we do a 14-day testing period. After all of those things come back, we have mama's records and everything all the way through the USP 71 testing, and they're clear, then we can put these cells out for other people to test. So if you have a difficult time sleeping at night, you can look up this website. It's called clinicaltrials.gov. It has more than 6,000 current clinical trials going on throughout the world. Anything you could think of, I don't care. If you say stem cells and Alzheimer's, it's happening. Stem cells and erectile dysfunction, it's happening. It's all on there, and you can read all about the studies that are going on around the world. You should also know that everything we do is according to the rules and regulations associated with the American Association of Tissue Banks. American Association of Tissue Banks means that if you want to be a bone marrow donor, if you want to donate a kidney or whatever you have to do, all of those guidelines that you must follow, we also have to follow in order to make this appropriate. The next part has to do with guidelines. It's a federal government guidelines, and I don't go beyond that. The only thing I will say in closing is when we speak to our physician groups, which we have about 1,500 throughout the United States, I will tell them, I don't care what product you use. And my salespeople hate that. They're like, Alan, what are you saying? My God, use our product. It doesn't matter what product you use. Bottom line is, as a physician group, you need to know what company you're using. Because every single day you will see stuff that pops up. Oh, look at this company's doing this. And, you know, we're treating Parkinson's and we're treating ALS and we're treating this. You need to know where your company comes from. I've been in this business about 6 years. I've been a physician for almost 30 years. But I've been in this business for about 6 years. And we developed this company specifically to maintain consistency in product. In our lab alone, to give you an example, in order to maintain certified good manufacturing practice, which they have to do like back here in order to do IVs and all that sort of thing, every single day on hard surfaces and on the floor, and they swab the personnel, you have to find out dynamically what the airflow is in that room. And that has to be tested every day. Once a week, every surface is plated to find out what it's like when nothing's going on in the room. You have to terminally sterilize these rooms once a week. A dedicated, specific company has to come in and clean all surfaces once a week, switching the compounds you use so that you don't make a bacteria-resistant microorganism. Right? When we go through the whole process as a lab, we spend between $12,000 and $15,000 a month just maintaining certification of a lab. So when I talk to these guys, they already know the science. It's not about, oh, geez, Alan, tell me about this great scientific stuff they want to know. No, these guys come in and say, tell me about your lab. What's going on in your lab? Show me your certification. Show me your compliance issues. I want to talk to your compliance officer. What's going on here? That's when you know you have a good physician, and that's really your job. I mean, you can read all the stuff on the internet all you want, but that's where you're going to get the source of information from the owners of your lab, because they have to do their research, and that's why we're here tonight. So that's principally it for me. I don't know, Kevin, did I answer that question? Oh, I'm open to questions. Yeah, if anybody has any questions, I'd be glad. Yes, ma'am. Okay, so mental health and neurodegenerative disorders. I will tell you that in the United States, because of FDA regulations, and sometimes that's a bane to us, and you know, sometimes it gives us safety because we know it's good. So around the world, there are multiple studies going on in progressive neurological disorders, neurodegenerative disorders, and mental health. What they found, they're doing a bunch of studies right now on schizophrenia, which the systemic use of umbilical cord stem cells around the world have been very successful. One part I didn't talk about in here because it's more for physicians. We have guidelines as a manufacturer and a distributor. And our guidelines by the FDA are directed towards us. The FDA governs what we say. I cannot market nor advertise anything that would have a systemic effect on your body. Right? I have rheumatoid arthritis. I can't sit here and say, here's what I'm going to do for you. I can tell you what's going on around the world, and that's what I would say about neurodegenerative disorders. There are multiple studies. There happens to be a study going on in Melbourne, Australia right now on Parkinson's disease, where they're specifically manipulating a cell. It's called parthenogenetics. They're manipulating a cell that creates dopamine, and they're injecting it into the striatum and the substantia nigra in the brain. You said neurodegenerative pretty good, so I thought you might understand that last part. And they're reversing Parkinson's disease. So, I mean, there's a lot of advancements around the world that are going on that are very, very positive. Yes, sir. Longevity is always the big kick, you know, and everybody's talked about that. If I take stem cells, will I live to be 135? Don't know. What they believe is, I don't know if it'll elongate your life, but the potential is to give you more quality up to that life. Around the world, remember I always say that because we can't talk about United States stuff. Around the world, the largest use for umbilical cord blood stem cells is the treatment of autoimmune disorders. In China, the number one treatment is erectile dysfunction, and they do it intravenously. But anti-aging and longevity is the big thing. That's what everybody is looking at. So nobody knows if it'll make you live longer, but the hope is you'll have more quality necessarily than quantity. Now, there are studies going on right now to see if it adds to telomeric length, right? If you have problems sleeping at night, read a book on telomeres. It'll take care of a lot of that stuff for you. But there's some studies going on right now about telomeric length, and that's a great potential right now. Now, you had a question earlier?
You answered. I was going to ask you the difference between the cords and the other one. You answered that. But I have a question on I've had stem cell treatment. You don't hear too much of people talking about IV first. You always hear about the direct, whether it's in the joint or whether it's in the neck. And normally, there is research done on IV tips, like you said, for fibromyalgia or different types of disease. Is that something that they're kind of care, sort of?
So she's asking, why don't we talk more about IV drip? Why don't we talk about systemic effect? Why do I always talk about joint? So it's called Title 21, Code of Federal Regulations 1271.1, paragraph 361, which is an FDA guideline for manufacturers and distributors. It says, number one, our product must be minimally manipulated. We follow that guideline. Number two, it must have a homologous effect on your body, as was the original source. In other words, what does the umbilical cord blood do for the baby? Does it do the same thing for you? Yes, we're okay with that. Number three, you can't add anything to it other than a sterile saline, a sterilizing product, or a cryopreservative. Number four is the biggie. And remember, these guidelines are directed towards us as manufacturers. We may not market, nor advocate, nor advertise anything that would have a systemic effect. So anytime you hear me talk about systemic effect, any autoimmune disorder, fibromyalgia, any of that sort of thing, I have to talk in terms of what research is going on around the world. Now, I will tell you, a physician is not governed by the FDA. A physician is governed by their state medical board. State medical boards generally say do no harm. So while as a manufacturer and a distributor, I cannot tell you this is what you should do for IV therapy, a physician can, because it's called empiric treating of a patient, and they can do that sort of thing. So if somebody asks me, hey, what do you know about rheumatoid arthritis? I would say, worldwide studies have shown blah, 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 right? Even though I know a large percentage of our product is used intravenously, I have to really walk that line because in order for us to stay in business, I can't be stupid. Yes, sir. Is cancer a contraindication? That's a great question, and it comes up a lot. The reality is there are multiple clinical trials going on in the world right now, and they've been going on for years, treating cancer with stem cells. So what they found out is that in the conclusion of these cancer studies, what they usually say is, we feel like umbilical cord blood stem cells, or we're comfortable in saying umbilical cord stem cells are non-oncogenic, and that they don't create cancer, and they're non-tumorgenic, and that they don't stimulate cancer to grow. So we believe they're not. Still, as a company, if somebody calls me and says, I know we're doing a knee injection, but the patient has, active prostate cancer or had prostate cancer, we technically follow the AMA guidelines, American Medical Association guidelines, that say you should be 5 years clear. What most physicians do is give informed consent and say, here's what the research says, here's what's going around in the world, you make your own decision as to what you want to do. Yes, ma'am.
The companies to which you sell, are they all around the world or here in the United States?
The clinics that we sell to, all around the world. I just got back from Costa Rica last night. And we have clinics in Costa Rica, Philippines, Vietnam, Indonesia. China's a tough one because every single province in China has a different rule. You know, some of them are legal, some are illegal. Central and South America, we do a lot there, fair amount in Asia.
I just got back from a fitness vacation. Someone was talking to me about a firm in Panama.
Sure, Stem Cell Institute, Neil Reardon. We know him well. Mm-hmm.
And they have a whole thing on whatever myo, how do you say that?
Mm-hmm.
The myo whatever cells.
Right,
How do you say
mesenchymal stem cells.
that's a kind
Right. Neil Reardon started in Dallas, Texas with Jack McKenna, who's an orthopedic surgeon. But and Neil Reardon was very much a pioneer. They were so far ahead of their time, he had to leave the United States because they knew the stem cells were there. They were trying treatments way before the FDA thought it was cool. And he went to Central America and went to Costa Rica. Got in a little trouble because he didn't follow all of the guidelines and went to Panama. He set up a very successful clinic in Panama, and he's probably been there 15 years. The average treatment at the Stem Cell Institute in Panama is $35,000 for 3 days of therapy. So yeah, and I know Neil. My team will tell you, he gives me crap every place we go. Yes, sir. Any services that would complement stem cell. The healthier you can be, the more anti-inflammatory you can be, the better it's going to be. There's absolutely no doubt about it. If you have less inflammatory components in your body, you are just going to be better off. I mean, I can't tell you the number of clinics around the world that when they use intravenous therapy, they will use Myers cocktail, glutathione. And Myers is like a kindergarten version of, you know, the vitamin therapies that you can really get at a place. But that type of thing that really puts your body and optimizes your body. Remember I talked about in there, as the mesenchymal stem cells work to optimize your body, once that area gets optimized, that's when the growth factors begin to work. If you are in an anti-inflammatory state, they work that much faster and they work that much longer. I remember I told you 86% of the patients with a knee injection don't have to have a second injection. What about the 14%? The 14%, when they've done analysis of the synovial fluid in the joints, they started with a higher concentration of inflammatory components in that injured site. So ironically, it's not the 80-year-old with 30 years of osteoarthritis. It's the 30-year-old who has an acute injury because they have a more powerful immune system that picks it up. Yes?
How long do you think it would take, your opinion, for this type of therapy to be available for the general public, but be affordable for the general public?
Well, I mean, affordability for the general public, at some point in time, probably in the next 5 to 7 years, it will become mainstream and it will be part of the insurance companies, and that is exactly why I quit surgical medicine. I mean, it's going to get there, right? It takes time. Innovative therapy can be somewhat expensive in the beginning, but I mean, eventually it will be covered by most insurance plans. Yes, sir.
Is it true that for IV push, you have to have patients' blood taken out and processed stem cells relative to the localized treatment for specific joints, like knee?
What do you mean pulled out?
In other words, you know how you were saying you have to take bone marrow and process that, because every candidate is not for the IV therapy.
Right,
If you want to do the holistic approach
right.
to the patient relative to localized knee pain, shoulder joint, whatever
Right.
the joint could be. So it is differentiated in any way, or one works all the way through?
So what he's asking is, if you have knee and shoulder and joint pain, could you just use it intravenously to get all of that at the same time, right? So that has to do with physiology of the body, right? If you say somebody has rheumatoid arthritis and all their joints hurt. So rheumatoid arthritis is a systemic condition. So if you were to give it in other parts of the world, systemically, yes, it would stop the systemic effects, but would have very little application on the joints itself. Ideally, if somebody has significant joint pain, it's better to put actually inside the joint. Because imagine, most patients that go to a pain clinic with significant joint pain are not 18 or 20 or 30 or 40 years old. They're usually 60, 70, 80 years old. And if that's the case, if you were to give it systemically in other parts of the world, where's most of it going to go? Right? It's going to sit up in the lungs, it's going to sit up in the kidneys, it's going to sit up in the liver. You got GI problems, you got spleen and all that other nonsense. You'd be lucky to get it in. You may get an overall systemic anti-inflammatory effect, but it's not going to directly affect the joints. Yes.
I was told that cartilage, the amount of cartilage that you get is all you get, and that it can't be regenerative. I was a little bit confused by what you were saying. It sounded almost like it could be rebuilt.
So she has heard that what you get with cartilage, what you got is all you get, right? Mostly true in most situations. However, think about this. What if you're 12 or 13 or 15 or 20 years old and you have an injury? Does that cartilage ever repair itself? Oh yeah, it absolutely does. No doubt about it. Because you still have those activated stem cells in your body. You don't have a high inflammatory component. Our body's not become toxic over time, and we have a strong immune system. Cartilage definitely regrows. It's called transforming growth factor beta, which is it's a normal growth factor that's in our body. So if you have somebody that doesn't have, as cartilage is missing on their knee, then the answer by an orthopedic surgeon is it'll never grow back. We need to cut it off, and we need to put on some titanium and make you feel better. 20 years ago, that was probably the truth. It's not anymore. The bottom line is get rid of the inflammatory components in that site, give nutritional support to the damaged cells, stimulate the healthy cells to regenerate, and hopefully you can grow some tissue. What's the problem? If you're 75 years old and those joints are pretty tore up, how much of your own stem cells do you still have in place? Probably not a heck of a lot, right? Yet studies have shown that cartilage can take a year to a year and a half to regrow, yet subjectively you will tell me at 3 months, I feel great. If we look inside your joint with an arthroscope, your joint still looks like crap. So what does that mean? It's the inflammatory components that create most of your pain. Can cartilage regrow itself? Sure, it can. But the biggest mechanism we're looking at for you and for me is pain. But the cartilage can regrow. That's definitely proven. It is definitely tied to your age. And over age 50, it becomes a little more perilous, yes.
Can we take 2 quick last questions? I know you've had a question for a while, and I think one of you guys, I want to be respectful of your time. Right here, she had a question.
Oh, yes, ma'am.
Thank you so much. I'm just going to try to formulate this quickly. So, in other words, if you needed it in your knees, you take the shots in your knees. If you've been told there's like some markers in your blood work that you may have a little bit of autoimmune, 70 years old, that healthy. So then would you take internally? Also, like, I know you can get the shots in the knees, but then how would you get it in to maybe address some of the other stuff?
Healthy 70-year-old with a little bit of autoimmune disorder and 2 knees that are hurting. What's the best approach? You know the first thing I'm going to say. In other parts of the world, what we would do is give, as a manufacturer and a distributor, intravenous application to stop the inflammatory component, the autoimmune component, and localized in order to help the regeneration at site. I mean, if you look at it in the big picture, somebody who has autoimmune disorder and has joint destruction, if you just inject the joints, the systemic condition will continue and will go back into the joints. Ideally, you could do both. If you had to choose one, I would do the joints.
And then what if you have like a shattered humerus, like so bone is missing? Could that regenerate?
So how about a shattered bone where there's some bone missing? Yeah, I mean, there have been a lot of studies on that, and that's very common, because one of the things that it does at the bony level, what is interesting in other parts of the world, they've treated patients with osteoporosis, and it creates osteoblastosis, which overcomes the osteoclastosis, right? As we age, bone builds up and bone breaks down. Unfortunately, as we get older, the breakdown becomes greater than the buildup, and we get osteoporosis. So you get a fracture in say a humerus. Can it help that? Absolutely, because the osteoblastosis in that bone is stimulated to actually create it. Do you need to put it locally? If that were your only problem, that's exactly what I would do. Put it in the site. Just got a call yesterday from I won't say his name, professional football player for the Kansas City Chiefs, and his first name's Mike. And his son broke a bone. And he said, you know, what can I do about it? What's the thing to do? Should we give him intravenous? Said the kid's only 14 years old. Inject it next to that area and give it the best effect. So does it have the potential? Absolutely. Yeah, no doubt about it. Yes, ma'am.
Yes, go for it.
I have an extreme prolapse disc between L5 and S1 and one between L4 and L5 S1. I was anti-surgery, trying to deal with it on my own with decompression therapy, PT therapy. However, I started to develop extreme peripheral neuropathy and am now considering a discectomy. What are your thoughts on that with your knowledge?
So you have an herniated disc L4, L5, L5S1, and you have some peripheral distribution of some peripheral neuropathy.
So I decided to go the surgical route because I'm afraid of that sciatic compression.
Sure. So she's asking, you know, if you have a herniated disc in those sites and you have nerve compression and you don't really want surgery, would it help? The problem at discectomy, you know, not too terrible, it's not bad. If you have a fusion, the problem is, what are you, like 19 or something like that? 35. Yeah, that's what I thought, 35. The problem with the fusion at 35, the problem of fusion at any age under probably 100, is that motion must take place in the body. And if motion can't take place at L4, L5, L5S1, over motion is going to take place at the levels above that. In 5 years, 90% of the people will require another fusion above that level. In 5 years, you'll require another fusion above that level. You're young enough that it's going to creep up. So is it a potential? Yeah. There are multiple studies out there that do intradiscal injections. So they inject into the disc with the cells. They follow it with a little PRP just to volumize it. And then they use a component called hyaluronic acid. And all that is a thick, viscous fluid, and it kind of keeps it all in sight. Studies that were originally done on that were done on dogs. So dogs are quadrupeds, right? And when you look at an MRI of somebody who has a damaged disc, you see, oh, these beautiful white halo discs. All of a sudden you see a damaged disc, it's gray or it's black. When they did the initial studies on dogs, when they looked at those dogs in 3 months, all the discs were white. It was halo white. It was beautiful. So they started doing them on humans. Well, we don't walk on 4s. We walk on 2s. So the gravitational force is much more. While the MRI results were not great by MRI, subjectively from the patients, the results were phenomenal. Because the MRI still didn't look super good, but the patients subjectively had less pain. They've also showed that the annulus, which is the ligament around the outside of the disc, actually healed. Now, thickening of the joint space is kind of iffy, not sure if that happens, but potentially if you have radiculopathy associated with the herniated disc, it's probably because of the herniation and not due to bony prominence. And the only thing that can tell you that really, unfortunately, would be, steroid. And if you got the steroid and you had relief for a period of time, it tells you that it's an inflammatory component, not a bony component. So what you want in that site is something that has anti-inflammatory effects. So yeah, essentially, what's that? Did not help. So you may have a bony prominence, or did they put it epidural or did they put it local? Localized. So epidural is probably where you needed to be on that. Still, even that, if your pain is transient, it's not always there. Sometimes you have it, sometimes you don't. It's worse with activity, better when you're not on it. You still have a chance for anti-inflammatory effects.
Amazing. Dr. Gavin, thank you so much. I want to thank you for, helping facilitate the progression of stem cells and sharing your knowledge. Our goal here at Next Health is to take these concepts and these topics that have potential to be massively impactful, but are also very complicated, and to make them as simple as possible, as easily accessible as possible, as affordable as possible, so that as many people can access this and can live the best life possible and be as vital as they can. So thank you guys all for coming. I think everyone gets a complimentary week of cryotherapy, right, Vanessa? Right? Yes? Awesome. Are they on here, or do we have to give them out? Okay, so Vanessa's going to be standing right here, and she'll give everyone who walks out a voucher for 1 week of cryotherapy. We'd love for you guys to come in and utilize it. And anyone who wants to learn more about stem cells, reach out to us. We are now doing them here at Next Health. We're ready to go, and we're excited to give you guys access to this. Thank you for coming.